Hello everyone, sorry about the brief interruption. Let's continue on discussing oogenesis. Actually, we were just talking about the difference between oogenesis and spermatogenesis. Actually, the main difference being that at the end of spermatogenesis, we end up with 4 sperm cells, but at the end of oogenesis, we're only going to end up with 1 actual oocyte and 3 polar bodies, which are incomplete meiotic byproducts, basically, that are not able to be fertilized. And that's because the ovum is going to have a very large amount of its own cytoplasm. So we're going to utilize all the cytoplasm from all of these different precursors to cells to make the one that's going to be utilized as the actual ova. Okay, all right, so let's talk about oogenesis. As I mentioned, follicles are going to be here in the ovary. They're going to be stuck basically in the precursor to maturation. So the very first step of the meiotic division, I'll step back here. The very first step of the meiotic division here actually is going to occur, these secondary oocytes, the immature secondary oocytes, are actually going to occur during embryogenesis. And then they're going to be halted until puberty. And at puberty, one at a time, these secondary oocytes are going to be able to be matured and released and potentially interact with the sperm to create fertilization, right? And that fertilization is going to go on to become this fertilized ovum. All right, so these are the precursors, these primary follicles that are halted at that first meiotic division. And that happens again during embryogenesis, and then they're halted all the way until puberty, and then one at a time they're given a context clues to enter into the follicular phase, where they're going to go from a primary follicle to a secondary follicle, which is a growing follicle basically, to a tertiary follicle, or again eventually a Graafian follicle, which is going to be rupturing. Now, the ovulation and the cycle, so the cycle of the ovaries and the cycle of the uterus has to be very tightly synced. So we're going to have them all kind of overlaid here together, but we're looking at multiple things. Here we're looking at the concentration of particular hormones in the bloodstream, like follicle-stimulating hormone and luteinizing hormone. And they're both going to give a quick surge, and that LH surge is going to give the ovulation event. So here's the follicular changes in the ovaries. Again, one oocyte is going to be given the opportunity to develop from the follicle per month. So that particular oocyte is going to be induced to develop follicular growth. Eventually, ovulation is when the follicle ruptures open. Again, that happens because of FSH and LH surge. And then that ovulation is going to then lead to hopefully fertilization in the infundibulum of the uterine tube, but additionally it's going to lead this region behind in the ovary called the corpus luteum, and the corpus luteum is going to secrete hormones as well, and estrogens, progesterones, inhibins. Basically, that's all going to signal to the uterine lining that it should stay and maintain the bed, because it should be expecting this ovulatory byproduct, which hopefully is fertilized. If it's not fertilized, it won't embed. But if it is fertilized, then it will end up embedding, and we need to make sure that we have the endometrial lining nice and thick. So again, the corpus luteum is going to secrete different hormones, estrogens, progesterones, inhibins, all of which is going to cause thickening of the endometrial lining, okay? So again, this is talking about the concentrations of estrogens and progesterones in the bloodstream. Again, we get a first spike, which happens when the follicle secretes estrogens, and then a secondary higher spike of progesterone and a lower spike of estrogen, which happens when the corpus luteum is going to have the maintenance of pregnancy hormones secreted, which is going to talk to the endometrial lining. All of this is going to be something that we can communicate with one another to make sure that the ovaries and the uterus are all kind of in sync. Now, these things here are things that we can test, the level of estrogens, the level of SH, the level of LH, etc. And we can utilize these for, like, for example, ovulation predictors. So we can use these to determine which part of the female cycle the female is in if a couple is having issues getting pregnant, so that we can tell them what would be their highest opportunity of conception. All right, so we start this whole thing off starting at day 1. And day 1 is going to be the first day of menstruation, and we utilize this because it's the easiest thing for women without any scientific background to be able to tell us as the nurse practitioner or the gynecologist, right? So when was the day of your last period? The first day of your last period is going to be day 1. So that's actually going to be, we're sloughing off, so we have another couple of days of the menstrual phase. Should take about 5 to 6 days to eliminate all of that menstrual fluid. And then we're going to start the next phase, which is going to be the follicular phase. Okay. During the follicular phase, the follicle is secreting estrogen. Estrogens are spiking in the bloodstream, and we are secreting that in order to create a nice thick endometrial lining. Then we're going to get the actual ovulation event by a surge of FSH and LH in the bloodstream. That's going to also be marked by a decrease in estrogen. but a slow increase in progesterone as maintained by the corpus luteum, right? So we're not going to have estrogen anymore because the follicle ruptures, it stops secreting estrogen, it starts becoming the corpus luteum, which secretes some estrogens, but also progesterone and inhibin, all of which maintains this endometrial lining so that this ovulated byproduct, which is hopefully a fertilized egg but might not be, is going to be coming through to embed into this nice thick endometrial layer. And if it's not a fertilized egg, then we're just going to start the whole thing over by shedding that endometrial lining. Endometrial lining is going to get nice and thin again, and we're going to lather, rinse, repeat, or start this whole process over. All right, again, ovulation is triggered when we have a surge in LH and FSH. This happens by the anterior pituitary gland. And then we also have the follicular phase here, which is when the follicle is growing and developing, which is going to secrete estrogens just prior to that follicular rupture, which is the actual ovulation event, right? And the last cell division of oogenesis only occurs if fertilization occurs. If it is not, if no sperm are present, fertilization does not occur, that last stage of oogenesis does not complete, it will not embed in the uterine lining, and again, the uterine lining will be sloughed off. All right, so again, that first meiotic cell division is going to be triggered when we have LH surge that happens during ovulation. We have specialty cells around here called granulosa cells. These granulosa cells here are going to be nourishing this developing oocyte and stimulate the creation or oogenesis. And then also we're going to have theca cells that are going to create androgens, and we utilize those to form estrogen. So as I mentioned, androgens and estrogens are quite interchangeable chemically. They're very similar very similar biomolecules. And so the theca cells are able to actually create androgens, and then we're going to transfer those into estrogen. Estrogen is going to be responsible for eventually leading to the ovulation event. Ovulation is actually going to be stimulated, obviously, by FSH and LH. And we also are going to be able to be making antral fluid. That's this fluid here. So these granulosa cells are going to be responsible for both converting androgens to estrogen, nourishing the oocyte, stimulating oogenesis, also making the antral fluid here, which eventually is going to come on, antral fluid here, which eventually is going to push outward and lead to rupture and produce something called inhibin, which is going to be part of regulating this whole cycle as well. Eventually, we're going to be creating inhibin again by the corpus luteum. After we ovulate, so after this follicle ruptures, the corpus luteum starts secreting progesterone. Progesterone is going to have a spike right then. Again, that's going to be involved, so they're having crosstalk between the ovary and the uterus. So this progesterone is going to communicate with the uterus that we need to keep that uterine lining thick in the event that fertilization has occurred. We're going to wait about 10 days to find out if fertilization has occurred. If so, this corpus luteum is going to maintain progesterone, etc., for the next 6 weeks until the placenta can take over. If not, in about, day 28 to 30, we're going to slough off and lather, rinse, repeat, and start over with the hopes that the next follicle rupture will lead to an ovulation event that is fertilized. Okay, so again, we leave it for about 10 days or so, nice thick endometrial lining, awaiting the byproduct of fertilization, hopefully that it's going to be a fertilized event, and if not, then it's going to be an unfertilized oocyte, the whole thing's going to be shed. Now, these couple slides are going to talk about different disorders of reproductive systems. One is called endometriosis. As I mentioned, the endometrial lining is that central lining inside the uterus. And if endometrial tissue becomes overgrown or grows outside of the uterus or into other organs, we can end up encapsulating things like the ovaries and the fallopian tubes, also any of the tissues or structures that hold the uterus in place. It can also start lining the outer surface of the uterus, growing all over the pelvic cavity. As we see, it's a tissue that is meant to continue to grow and slough off and grow and slough off. So it's very good at reproducing. And if it continues to reproduce aberrantly, it can end up taking over the abdominal cavity. This can be extremely painful and can lead to issues with fertilization, right? So this individual might end up with fertility problems. This slide talks about the effects of aging. So as we get older, we're going to lose our reproductive capacity. In males, this is going to be shown as a decrease in the size of their testes. The actual mass of the testes will become lower. Also going to have a loss of testosterone production. So less testosterone production means less sperm produced, and less sperm is going to lead to a gradual reduction in fertility. We also can see erectile dysfunction. So we can see issues where we are unable to maintain an erection, so we can't get to the actual ejaculation event, etc. So obviously that's going to be a barrier to fertilization as well. In ladies, we can enter into menopause. We will enter into menopause somewhere in our mid to late 40s, early 50s, where our estrogen is no longer being produced by the ovaries. So the ovaries are no longer creating our female hormones. That means the only sex hormones that we're getting are coming from the androgens that are created by the adrenomedulla cells And that means that these guys are going to be converting androgens into estrogens. This can see some menopausal symptoms due to the reduction in hormone levels, such as vaginal atrophy, vaginal dryness, irrational fits of rage, right? Loss of sexual arousal, etc. And so we can utilize exogenous hormones that we get typically from mares. So we have something called pregnant mare urine or premarin, and that's going to be a hormonal supplement that menopausal women can take to help restore their estrogen or hormonal levels. There are some health risks associated with hormone replacement therapy, so obviously this is something that you want to discuss directly with your doctor. Thank you so much for taking the time to listen to class today. And I really appreciate you guys coming to my class. And I hope that everyone has the chance to complete all of their assignments and get everything submitted on Canvas. And if you have any questions at all, please feel free to reach out, email me, or text me. And it has been an absolute pleasure having you in class. Happy studying. Have a great day.